sorry we are running slightly later as our photo together and our very actively conversation. Okay, let's start our second session after our tea break. First, we are very sorry another chair for this session, Dr. Mei from Portugal. She is not here because of the failure of her visa to the UK. I don't know if this is early impact of the UK referendum from the EU. I don't know what's the reason, but I'm very sorry she's not here at the moment. So I will come like a local to replace this the chair with my colleague, Professor Zhang Chao. Professor Zhang is the leader of our North Group of Association of Traditional Chinese Medicine and Acupuncture UK. He was the chief doctor from Tianjin TCM Hospital. Now he's running his very busy business in Manchester. Myself, I think we have introduced. So first, welcome our first speaker, Dr. Beverley. Sorry for my... Yes, please.
Thank you. So can you hear me?
Yes.
Okay, so following on from my esteemed colleagues this morning, I'm just going to quote Monty Python and say, and now for something completely different. So I'm going to talk about a study that I'm doing currently that we're about a third of the way through. It's about teaching patients in the National Health Service in the UK to self-administer moxa to stomach 36 while they're undergoing chemotherapy. And so I'd just like to acknowledge my funders on this study, the British Acupuncture Council, and also the Lyndon Jackson Macmillan Centre, where I am a member of the supportive oncology research team. I'm the research acupuncturist there. And this is all taking place at Mount Vernon Cancer Centre, which is a cancer treatment centre on the northwest edge of London. This is the team. And I just need to make a correction. Claire Scarlett there is not our data administrator. She's our health improvement practitioner, and you will see more of her later in this presentation. And this study has gone through all the requisite approvals. It's badged in the NCRN, which is a great door opener in terms of doing this study in our cancer centre. We have ethical approval and local research and development approval. And the study descriptions are made publicly available on the UK, the CR UK, and the Clinical Trials Government websites, so in the UK and the States. And our intervention, as I said, we're teaching chemotherapy patients to administer moxibustion daily to stomach 36, and this is with the hope of reducing chemotherapy-induced pancytopenia. So I don't think I need to tell you what moxibustion is here, okay, but we know it sees to warm points, and there are many ways to administer it. We're using smokeless stick moxibustion in this study. And I think we all know that Zusanli stomach 36 is a very important point in the Chinese repertoire. It's the most important point to generate qi in blood, to tonify the qi of the whole body, to preserve and maintain health, to prevent illnesses. And Qin Cheng Zhu, and you must pardon my Chinese pronunciation, tells us that all diseases can be treated using this point. So why do we want to do this? Well, you probably are aware that chemotherapy agents reduce bone marrow activity, and this can result in a number of consequences. And so chemotherapy-induced pancytopenia is an umbrella term for the three consequences that may occur. So when the white blood cell count is reduced, we may get leukopenia or neutropenia. The red blood cell count results in anemia, and platelet counts result in thrombocytopenia. And any of these has a potential impact on the chemotherapy schedule. So they may cause a dose reduction or a delay in chemotherapy or both. And this has a knock-on effect on survival, and especially in curative or radical chemotherapy. These delays and dose reductions also have an impact on patient experience and quality of life, and of course they have an increased cost burden to the health system. So looking at neutropenia, it comes in two flavors. You can get severe neutropenia or febrile neutropenia, and febrile neutropenia is life-threatening. So there's a serious risk of infection and sepsis. This has a really serious effect on chemo schedules and survival, and the literature tells us that about 20% of patients experience either severe or febrile neutropenia after the first cycle of chemotherapy, and this can rise to 30% during cycles 1 to 4. So the cost to the NHS has been calculated at being between $2,300 and £3,500, and it costs more if the patient requires care in a high dependency unit, which is the case in neutropenic sepsis. So there is prophylaxis for neutropenia in the form of granulocytic colony stimulating factors, or GCSF. It is used, there are tables, recommendations. Chemotherapy regimens where the risk of febrile neutropenia is over 20%, then GCSF is used as primary prophylaxis. And if there is a risk of 10 to 20%, then it's secondary prophylaxis. The problem with GCSF is it's not indicated for all chemotherapy regimens, or for all cancer types, or all stages of cancer. It's also costly. It has some patient acceptance issues in that it is administered through self-administered injection, and there are side effects, including bone pains and aches, musculoskeletal pain, red itchy skin, fevers, chills, fluid retention, and breathlessness. So if you have a patient who's already suffering the consequences of chemotherapy, you don't want to add more side effects. Moving on to anemia, there is a very high incidence, particularly with lung and gynecological malignancies, platinum-based chemo regimes, and some of the new cytotoxic agents and the very intensive chemo regimens. And so the literature tells us that it occurs again in about 20% of chemotherapy patients during cycle 1, and it rises to about 50% by cycle 5. So it's treated with blood transfusion, with erythropoiesis stimulating agents, or iron supplementation and monitoring. And there are associated side effects and cost implications of all of these things. Thrombocytopenia is possibly the least worrisome of these three conditions, unless this is bruising, and unless it's accompanied by heavy bleeding. It usually goes untreated, but it is observed. And if it becomes extreme, then platelet transfusions are given. So how can moxibustion help with all this? Well, it's used in classical and modern practice of Chinese medicine. Oh, thank you very much. Thank you. To stimulate, I need to change this word, to harmonize the immune system and to nourish blood. And so there may be a potential there to reduce chemotherapy-induced pancytopenia, and it may affect the incidence or the severity of neutropenia, anemia, and thrombocytopenia. The literature also tells us that it may reduce other side effects of chemotherapy. So there are some papers talking about reduced nausea and vomiting. It's very good for fatigue, apparently. And there's a developing evidence base, and some of this is animal research. There are some RCTs. There's a more clinical observation in case studies and anecdotal studies. So looking at the evidence base, the lab studies are mostly done in the Far East, and I don't speak Chinese, so I need to rely on interpreters. So Zhang and Lau in 2012 and Wang and Sega 2010 have summarized the research, but there are reports of improved immune cell function in the literature. In 2014, Choi and his team published a systematic review of clinical studies in China, and they reported higher white blood cell counts and platelet counts in the moxa arm compared with the control group. And they also reported these reduced side effects and improved quality of life in chemotherapy patients. And so Choi and his team concluded that there's a low level of evidence demonstrating superiority of moxa over controls in management of chemotherapy-induced pancytopenia. So are you all familiar with reading the systematic reviews? Okay. Doesn't sound very optimistic to say a low level of evidence. It is extremely optimistic. Yeah, it's very good. You know, the way that they're written, they usually say there's no evidence for this. So a low level of evidence is pretty positive. So in terms of randomized control trials, there have been 2 done in the West. They don't rely on moxibustion alone. In fact, the first one done at the Dana-Farber Institute in the States, looking at ovarian cancers, used acupuncture, and they used heat on a point rather than moxibustion. But they reported a higher leukocyte count, less incidence of leukopenia in the intervention group over sham. And in Portugal, more recently, a small study was done with colorectal cancers, where they used moxa on the needle, on some needles, and they reported an increased white blood cell count, absolute neutrophil counts, B cells, NK cells, and less anxiety and depression in the acumoxa group compared to no intervention. So my work is based on the clinical reports and case studies that have been published in the UK. Friedrich Stabler published his evaluation of 20 years of clinical experience. He teaches his chemotherapy patients they need to come with a partner. He teaches them how to moxa the Magnificent Six, and they moxa that every day. Davies found that she had a single patient who didn't have a helper to help her administer this, and so she taught that patient to use self-administered moxa on stomach 36 and reported that case study. So we're building on that work. So in our study, our aims and objectives at this stage, we're starting at a very initial level. We want to assess the feasibility of integrating this intervention into a typical chemotherapy schedule. So we want to know if patients in the NHS are interested in this thing called moxibustion, because it isn't commonly practiced in the UK. And whether they want to participate, and we want to know if they can actually adhere to a daily procedure over a long time. So we're asking them to do this for over a 6-month period. But while we're doing that, we want to collect some data for a second study. We want to see if we can have any effect on reducing chemotherapy-induced pancytopenia. We want to see if this helps people to complete their chemotherapy schedules according to schedule. We want to collect some preliminary data on reducing other chemotherapy-related toxicities and whether we can improve quality of life. We want to see if this is acceptable to patients and to the oncology healthcare professionals. And we want to report any adverse events of moxibustion. And this is something that's often lacking in the literature. So I never overpromise, I always underpromise in the hopes that I can underdeliver. So this is a phase 0 uncontrolled observational single-arm feasibility study, right? Okay. It's single site at Mount Vernon Cancer Center. Our aim is to recruit 25 participants, and we're using mixed methods. So all the quantitative data is what I just said, the adherence to moxa protocol, blood counts, patient self-management, safety. And then we're going to do some focus groups and some interviews with patients and oncology health professionals to assess the acceptability. And again here, so we're collecting our adherence to moxa protocol. Our participants keep a daily moxa diary. They will log when they've done it, and they will give us a reason why they haven't done it on the days they haven't. We'll get blood counts out of patient records, as well as the completion of the schedules and the chemotherapy-related toxicities. We're using a number of quality of life measures, FACT-G, which is the general FACT questionnaire for chronic disease, cancer, and FACT, the specific anemia and neutropenia questionnaires, and you can see how often we're delivering those. We're also using something called the patient activation measure. We want to see if we can use that as a tool to screen out patients who may be suitable for this, if we were going to implement it as a regular practice. And obviously, we want to monitor safety. So we're looking at patients with breast, gynecologic, or colorectal cancers between the age of 18 and 75 who are undergoing radical or adjuvant chemotherapy for early disease or first or second line chemo if in the metastatic setting. And they need to be commencing a course of chemotherapy for which G-CSF is not indicated. They need a life expectancy of over 6 months. And of course, they need to be able to understand the instructions for self-administration of moxa and to be able to carry out the procedure, able to give out informed consent. And we're excluding patients who have severe medical problems, cognitive impairment, hematological cancers, or who are receiving G-CSF. So our intervention is kind of a two-step intervention. So ideally, up to 10 days before their first chemo, they will meet with Claire, our health improvement practitioner. She's going to explain the whole concept of moxibustion, demonstrate the procedure, get consent, and then she's going to teach them how to use moxa, how to find stomach 36. She's going to really make it clear that it's very important to do this daily. Bilateral stomach 36, and we're choosing to do 3 minutes each side. There's not a lot in the literature about what the dose is, so this is kind of, we're experimenting with dose here, and so we don't know if that's a low dose or a high dose, but we reckon that this is what patients might do, and we might avoid burning sensitive skin. They need to learn how to use their daily moxa diary, and then we'll give them some materials. And then about a week later, we hope to meet them again and get the participant to demonstrate that they can actually handle the moxa safely, address any concerns, and give them their full pack of moxa supplies and send them on their way. That's the theory. It's not working quite like that. And here you can see this is Claire. She's demonstrating the use of moxa. And this is just really, they're going to do this every day throughout the full chemo schedule, and we want them to continue for 3 weeks after the end. And we're promoting this, that this is easy, it's less than 10 minutes a day. So I conceived the idea for this study and applied to the British Acupuncture Council for some money and got the money, and then got back and thought, well, that's okay, but I don't see how I'm going to make this fly in the NHS, because I work with some very skeptical oncologists, and as they say, one of them has said to me, I'm an acupuncturist, I've done acupuncture, but moxibustion is a bit far north. And another one said to me, well, we can get our heads around acupuncture, but moxibustion we just don't get. So I was going to have to do some work to convince these people to get on board with me. So the 3 areas that I was concerned about was our own research team, the oncology healthcare professionals, and potential participants. Because our participants, when Stabler, in the RCTs, and when Stabler and Davis were doing their work, these people were coming for acupuncture. So they had bought into the idea of acupuncture. So if the acupuncturist tells them to use moxa, that's just another thing that acupuncturists do. These participants are not having regular acupuncture. They're not having acupuncture with us. So we're approaching patients cold and presenting them with an idea that is outside of our culture. So we're also introducing a new and very novel intervention at a crisis point. Okay, so our treatment center, kind of has an embargo on approaching patients just at the point where they're starting chemotherapy, because it's a very vulnerable point, and patients have to take them on a lot just to manage their chemo. So I did some work, and so to establish credibility in the research team, I knew that from very early on that Claire was going to be the person responsible for recruiting and training these patients, and I wanted her to have an experiential rather than a theoretical understanding of using moxa. And so she didn't have to do this, but she did agree to do self-moxa herself, and she did that for a number of months. And this was very helpful because, you know, when you're a practitioner and you've been using moxa for years, you kind of forget some of the basics, strangeness of it. And so she would come back with problems and questions. And that was really, really helpful in helping us kind of shape some of our literature and identify some of the problems that participants might have. And it also gave us feedback on what moxa might be useful, what lighters to use, what extinguishers would be good to use. But it also increased her confidence in explaining and demonstrating the intervention, and she had additional ideas. So she's very into mindfulness, and so she promotes this as a thing that people can do, you know, to take time out for themselves during the day. Within the NHS setting, I had to be quite careful. I'm going to start kind of in the middle here. And so the thing that I started off doing was doing informal demonstrations. So I'd pop up with a moxa stick in front of the chemotherapy nurses or an oncologist and say, we have some funding. It's always a good entry. They know you're not asking for money. You've got money. You're bringing money to the table. To do a novel intervention, that prepares them, okay, of using this technique to help people get through their chemo more easily. And I learned that it was better to give them the experience, and so I would moxa their stomach 36, and you know, I got a range of responses, but overall the response was very, very positive. And the chemotherapy nurses would just go, I can think of patients who would really like that. So that was positive. I had to rewrite my protocol, so when I wrote my protocol for the grant, the British Acupuncture Council knew what moxibustion is, they know what stomach 36 is, and so I didn't really have to go into that too much, but I needed to go into that in great detail, in a way that the medical community would be able to grasp, so I really had to have a lot of evidence base there. I needed to discuss the mechanisms of moxibustion, the adverse effects, the costs, to make that a convincing document. And that was really helpful because one of the oncologists was just so excited by this. She said, can I do anything? Can I help you? And so she helped, she reviewed the protocol, she helped a lot with the medical terminology, and that made it a better document. And that is published now. The European Journal of Oriental Medicine published it in their summer issue this year. I have a few copies and it's downloadable from our website, so you can download that. And then we presented at formal meetings, and the formal meetings were the tough ones because that's where the skeptical oncologists gathered to say, well, you're not going to get any useful information out of this because it's not a randomized controlled trial. And by the way, can you smoke your moxa stick? So we felt it was, in terms of supporting potential participants, we developed a number of tools, and these were outside of our grants, so we had to fund these ourselves. The participant information sheet, of course, is something that is essential for recruiting patients to study, so they get that. But then we also decided that some patients like to see the evidence. So we summarized the research evidence that we cited in the protocol, and we made that available on the Linda Jackson website so that they can see, if they want to see what evidence is underlying this, they can. We then developed a very detailed instruction leaflet. This is the illustration from that. And we're lucky at the Linda Jackson Center to have an in-house information design team, and they've won many awards, and they've written this document to meet the Department of Health Information Standards. So that means it's clearly written in a language that the public can understand. And then we also developed a video that demonstrates the procedure so that patients can be supported by written and visual information. So we've made all of these support tools available on the Linda Jackson website, where the patients are given a phone contact if they have any difficulties. There's an emergency number, and they follow up with Claire, the health improvement practitioner, every time they come for chemotherapy. So she keeps really in touch with how they're doing, what their experience of using moxa is, and we're finding some very, very interesting things. I think if you give people a tool, it's always amazing what they do with it. So we were very lucky. Our first submission to ethics was successful. They didn't ask a single question about moxibustion or safety, so that is, we wrote our protocol, we wrote our stuff really well. Recruitment opened at the end of February. Never open your study on the last day of the month because people count that as a month that you've been doing, okay? Actually, we have 10 participants today, so we are recruiting less rapidly than we had anticipated, and that's usually what happens in studies. We thought we would have 5, we thought we'd get 5 patients a month, but we're getting 2 a month. I'm not going to blame one of the oncologists who said, oh, 25 patients, I can give you those, and we're still waiting for the first one from him. We've had really positive, constructive support from the oncologists and the chemotherapy nursing staff, and I'm kind of really overwhelmed by how positive they have been. And we've had increasing interest from other of the oncology health professionals. So we have one doctor one oncologist from another hospital who's been saying, I want my patients on this, and how can he's been reading the protocol to see how he can work his patients in. So that's really positive. And then, as I said, we have this publication of our protocol. The challenges that we're finding is that we aren't very able to recruit the patients in the 7 to 10 days before the chemo starts. Sometimes we're lucky to get them on the day of the starting of ovarian, and so we've just written an amendment to our protocol where we're seeking to recruit up to the end of the first chemotherapy dose, and that has something to do with the way the structure of Mount Vernon and the local district hospitals. Patients tend to be seen in the district hospitals and then sent to Mount Vernon for the chemotherapy. So they arrive at Mount Vernon for the chemotherapy. So that's probably a local issue. We're competing with other studies. There's a lot of research going on, and in our own research group, we have researchers looking for patients who are about to start their chemotherapy. We're competing for the attention of very, very busy clinicians to refer patients. And so we're addressing this by Claire goes to all the clinics and just reminds them that this study is going on. She's got a very, very good relationship with all the oncology nurses, and so she can remind them. She's designed some very bright flyers summarizing the inclusion and exclusion criteria, and she hands those out like candies to everyone. One of the oncologists said, if you put these stickers on patient notes, then we'll remember to think of these patients for the studies. And as I said, building relationships with the oncology health professionals. So that is the study to date, and we're hoping to complete it by the end of the year, and we'll have some results then. And so that's my contact details, and if you have any questions, please ask.
Thank you, Dr. Valois, for your exciting report. For practical, clinical practice reason, we all very familiar. Moxa or Starbucks 36 is not a challenge, but for research involved of the conventional medicine of the NHS system is how difficult, how challenge. So Dr. Valois provide us a possible method, a possible way to join the system to study clinical trial. This is, I think, very attractive for us, for our participants. Hope we can, in the future, to provide more this kind of clinical trial to publish for public to understand what is Chinese medicine and acupuncture. So this is my understanding. Now we have 2 questions. Any question?
Thanks a lot for your interesting sharing. I have just a question about how did you manage to obtain the consent? You mentioned about the consent forms, and you have successfully managed to pass the ASCO panel review. So about having access to the participants, how did you manage that? And also regarding the sample size, how did you reach the conclusion of having this sample size, please? Thank you.
Okay, so the sample size is just based on, we do a lot of kind of feasibility studies, and I think, 25. Actually, the reality is that was how much money we had. Okay, that's the reality. Yeah. And I'm sorry, I missed your first question.
About the consent forms, how do you have access to your participants?
How do we have access to them? They're referred in by their oncologist. Okay, so that's why it's important that Claire is at the clinics and we're reminding the oncologists. And it's kind of very important. We're finding that it's very important to have, with a novel idea, a wacky idea, it's best if the oncologist refers them in, because the oncologist then stamps his approval on that. And we're finding that very useful. But the oncologists also do a lot of sorting and sifting, and so they can identify pretty accurately who might be suitable for this study, and that saves us lots of time. Yeah. Okay.
Thank you. That's a very, very interesting study, and I do think that will give a good chance to understand. In your slides, I'm not quite sure if I understood it right. You're recruiting patients from when the first chemotherapy start, before the first chemotherapy starts. That means you don't know the patient already have damage to the blood system, or the patient have already demonstrated blood system damage, because the chemotherapy haven't started yet.
Yeah, but you're trying to prevent damage to the system.
So the whole system is about preventing.
It's about prevention.
Okay, so you don't treat. Actually, the people have already demonstrated evidence that.
No, the idea is that.
The evidence is preventing.
So we can't really, in this study, we can't really tell how effective it is, and so the next study would be looking at a controlled trial where you have a control group that aren't getting the intervention. But in this one, we're just trying to see whether we can recruit patients. Again,
Okay.
It's a novel idea, so.
All right. Okay. Thank you so much. I understand. So it is basically to observe if the people have this expression, and then in the group of 25, how many of them develop actually?
Yeah.
So it could give us a better idea.
Yeah.
Thank you so much.
Okay.
Thank you so much. Because of time, so we leave other questions during our lunch break. I'm sorry for that. Thank you for that.
Thank you.
It's a very exciting time.
I have some handouts and things, so if you come and see me, or I'll leave them on a table somewhere and you can pick them up.
Okay, thank you Valois again to give us a successful speech. And thank you Dr. Wang, and introduce me. Next speech is Dr. Wang Zhuhou, come from USA.